Hi, my name is Talia Caden. I'm an associate professor of ophthalmology at Northwell Health, where I'm also the director of the Vitreoretinal Fellowship. I'll be speaking today about managing geographic atrophy in 2026. Here are my financial disclosures. So let's start by just talking about what geographic atrophy really is. So geographic atrophy was really first described in 1880s by Otto Hab, but Don Gass is the person who came up with the name geographic atrophy in the 1970s. It's the most advanced form of age-related macular degeneration that's non-neovascular or dry. It's characterized by atrophic lesions of the retina, the retinal pigment epithelium, or the RPE, and the choriocapillaris. This is also known as cirrhora. Generally, geographic atrophy begins in the perifoveal area and then expands progressively to involve the fovea. And the median time from non-subfoveal GA to foveal involvement ranges from anywhere between 1.5 to 2.5 years, so not a long time at all. The median time to progression to legal blindness is about 6.5 years. Let's talk a little bit more about cirrhora. Cirrhora is defined as the complete RPE and outer retinal atrophy. And there are some criteria on OCT that we use to diagnose cirrhora. These are a zone of hypertransmission of greater than 250 microns, a zone of RPE attenuation or disruption of greater than 250 microns, evidence of overlying photoreceptor degeneration like ONL thinning, ELM loss, or EZ or IZ loss, and the absence of a scrolled RPE or an RPE tear. And you can see some examples of cirrhora in different imaging modalities on the side of the screen. So we look at OCTs all the time, but do the findings matter clinically? But do specific OCT findings matter clinically? The answer is yes. So incomplete RP and outer retinal atrophy, or iRORA, has a 5 times greater risk of progression to geographic atrophy or cirrhora. Hyperreflective foci, which you can also see on OCT, also carry a 5-time greater risk of progression over a 2-year period. Subretinal drusenoid deposits, also known as reticular pseudodrusen, which we can see on OCT, again have nearly a 5 times risk of progression over 2 years. So it's important to pay attention to what we're seeing when we look at the OCTs of our patients. Let's talk about why progression matters and how it matters for our patients. Here's a nice image that demonstrates how atrophy can evolve over time. We see on one side that you have a small area of atrophy which coalesces over time, often in a C shape. And as that happens, patients really notice that there is a deterioration of their vision that evolves with time, including the loss of central vision at the end, at which point they often feel as if they can no longer see despite the presence of peripheral vision. What can impact this growth rate? Well, we know that multifocal lesions have higher rates of growth, that eyes without subfoveal lesions have a greater atrophy progression at a year, that larger baseline size is associated with higher rates of progression, and again, reticular pseudodrusen can be associated. Does this matter for our patients? The answer is very much yes. We know that 100% of patients living with geographic atrophy will report difficulty reading. 75% of them may report difficulty with driving, and 63% of patients report that they have difficulty with their activities of daily life. This also impacts patients' quality of life. Patients with GA have a higher risk of developing depression and anxiety, which can result from the loss of independence and difficulties with those ADLs. Patients with unilateral blindness from AMD may actually demonstrate more depression than patients who are bilaterally impacted. And the reason for this is often due to fear over what life will be like when they lose the vision in their single functioning eye. Patients are often more likely to suffer a fall, and in a prospective cohort study from the late 90s, Medicare patients who had AMD with GA often had a higher rate of hip fractures compared with patients who did not have AMD. So what can we do for our patients? Well, there are 2 approved drugs for geographic atrophy at the moment, and these are pegcetacoplan, which was approved in February of 2023, and avacincaptad pegol, which was approved a few months later in August of 2023. Both of these are inhibitors of the complement cascade. So what is the complement cascade, you may be asking? Well, it's an important part of the immune response. And it's been well documented in genome-wide association studies that it plays an important role in the development and progression of GA. Pegcetacoplan will inhibit the complement cascade at C3 and C3b, while avacincaptad at PEGAL inhibits at C5. There are also lots of investigational agents. Here is just a brief list of some of the things that have been studied recently, including some that are actively still in studies. This includes a J&J product, which is looking at gene therapy with a single injection, another product that's looking at subretinal development for geographic atrophy, and another intravitreal trial, which is in phase 3 at the moment. So there are exciting things coming down the pipeline, but at the moment we have 2 approved drugs. Let's go through some case examples. This is an 82-year-old woman who has 20/50 vision in her eye. This is what her fundus photograph looks like, and this is her autofluorescence, where you can see those hypoautofluorescent lesions associated with the geographic atrophy. When we look at her OCT, you can see clear evidence of the C-RORA. So how do we talk about complement inhibition with our patients? Let's start here with a patient example. This is an 82-year-old woman with 20/50 vision in her right eye. Here on the near infrared, you can see evidence of both the drusen and the geographic atrophy, which is also seen on the B scan of her OCT, where the C-RORA is quite visible. On color fundus photography, again, you can see both the atrophy and her drusen, and her autofluorescent is consistent with that as well. So as we see these patients, it's important to think about how we should counsel them. Do we suggest or offer the use of these complement inhibitors? Assuming that the other eye looks the same, do we treat both eyes? Do we treat them both on the same day? What about if the other eye has count fingers vision with central atrophy? Does that change which drug we use? Do we try the drug in the poorer seeing eye first? These are all important questions for us as clinicians to think about. Now, here's this patient 2 months later. When she comes to see me, I see that there is evidence of a small amount of intraretinal fluid. So then the question becomes, what's going on? Is this actually evidence that she's converted from non-neovascular to neovascular AMD, which we know is a common risk with these drugs? So how do we think about that, and what do we do to assess whether or not we need to treat? In this case, I did a fluorescein angiogram for the patient, which demonstrated an absence of any leakage, which would have been consistent with the neovascular membrane. In this case, we elected to continue with her treatment. But it's important to think about what we do in these circumstances. Do we offer the patient simultaneous treatment, which is how it was done in clinical trials? Do we have them come back on another day for the complement inhibitor injection? Or do we stop treating with the complement inhibitor and just continue treating for the neovascular membrane? None of these are wrong or right answers, but it's good to think about in advance of seeing these patients so that you're prepared when you do see these patients. Here's another example. This is a 70-year-old white man who was referred in for possible complement inhibition therapy. When we look at his OCT, again, we see that there is that atrophy, but there really is no other evidence of AMD. I don't see any drusen. And when we look at his autofluorescence, there's just that large central hypoautofluorescent area. In this case, I elected to send out genetic screening and demonstrated that this patient did not have macular degeneration, but rather had an inherited retinal disease and was not a good candidate for complement inhibition. This is a reminder that we should always look at all atrophy and make sure we know we're treating geographic atrophy for macular degeneration and not atrophy from another disease. And here's a third patient. This is an 83-year-old person who came in with 20/50 vision in the left eye. Now, the patient also has glaucoma. This is an image I took just a few weeks ago, and you can see that the patient has these scattered multifocal areas of atrophy. So they are a pretty good candidate for complement therapy, and I have been treating the patient. But when do we start? And what did the patient look like before? I went back and looked at some of the RNFL images that we had. And when you look at the near infrared on the RNFL, you can see going back as far as 2016, there are small areas of atrophy. As we move into 2018 and then 2020 and 2022, you can see those atrophic areas are growing in size. but I had not yet seen the patient. They had not been referred to me for an evaluation. It was only when the patient came to me in 2024 that we finally started treatment, and this is what the patient looks like today. And again, I query, when do we start patients? When should we initiate any kind of therapy? And when should they be referred in? I would argue that any patient today with any kind of atrophy should be seen by a retina specialist so that if they're a good candidate for complement inhibition, they at least can have that conversation with their doctor. So some final questions to consider. Who is a good candidate for complement inhibition? How should we be discussing this with our patient? And how do we make sure that we're really best serving our patients, that we're using clear imaging guidelines for identifying and monitoring GA? And this may be aided by the use of AI in the future. We want to make sure we're talking about the risks and benefits and alternatives with our patients. And as a field, we want to make sure that we're continuing to develop new therapies and improving what we have so we have better options for our patients. I'd argue that there's a lot of room for growth, but we're definitely on the upswing. Thank you.